Yeah, I'm supposed to talk on women and access to STEMI care. And I'd like to thank Dr. Thomas Alexander and his team for giving me this opportunity. Now, this is, I think this face is familiar to all interventional cardiologists because she is the pioneer of primary PCI in the world as such. And she has done a lot of research on STEMI in women. And what she said was women have a smaller vessel size, less collateral flow, more vascular stiffness, and younger women, they have less extensive disease, but they have lesser myocardial preconditioning, and therefore they might have a higher mortality. Now, I'd like to show you the image of a 62-year-old staff nurse. Mind you, she is a staff nurse, a medical personnel, and she has been having cardiac pain for the last 7 days, on and off, and for the previous 4 days, she was getting prolonged chest pains, but she disregarded them as acidity. But finally, on presentation, because it was of severe nature, she came to us. And we could already see that there were Q waves formed, and you can see that the LAD is totally occluded. And therefore, we undertook a delayed PCI because of the ongoing cardiac pain, and this is what the angiogram showed. After the angioplasty, we opened the vessel nicely, but she has some residual myocardial damage. Now, ST segment elevation myocardial infarction is the most severe. It is the most time-sensitive acute coronary syndrome, and primary PCI is the treatment of choice. I'll tell you another story, a real-life story of Mrs. Yates, who had a severe cardiac pain at 11 p.m., went to a nearby district government hospital at 12 midnight with cardiac cath lab, was asked to attend a private hospital again with CCL as cardiac cath lab, kept there till 7 a.m. in the morning. We don't know why. And from there, referred to a teaching hospital. Maybe there were some payment issues where, again, with the cath lab facility, our dwelling time was again till 12 noon. Goes to another hospital, again 12 kilometers away, was advised primary PCA with the cardiac cath lab facility, but they were not confident there. They come back to another corporate hospital in the city at midnight 12, so almost 24 hours, and gets a delayed primary PCA. And he has resolution of chest pain, but with an ejection fraction of less than 35%. Now, there have been several studies regarding sex differences in outcome after STEMI, and this is one such study which came in JAMA in year 2018, and this is the international survey of ACS in transitional countries. There are about 12 transitional countries. And here you can see which included Siberia, some of the Russian countries, etc. And you can see that this included some 8,834 subjects with ACS. And you can see that the mean age in females was 66, so it was significantly higher. Diabetes was higher in females. Systemic hypertension again was higher in females. Current smoking was higher in males. Prior angina was higher in females, of course, and prior MI was higher in males. And you can see that heart failure again was higher in women, and prior stroke was also higher in women. So you find that the comorbidities were kind of higher in females, and the mean age was also higher. Now, if you look at the primary PCA population in this particular cohort, you'll find that, again, the age was higher in females. The diabetes is also higher. The hypertension is also higher. So practically, I think almost the parameters were same, indicating that women with STEMI had a higher comorbidity. And if you look at the time from symptom onset to admission, less than 2 hours, you find that younger women, actually there is not much difference. The younger women, that is younger women and younger men, dark blue is women, they presented almost equal proportion. Whereas you find the older, that is 60 to 74 years and more than 75 years, actually the men presented significantly much earlier than women. So meaning that elderly women presented much later. So this is they're trying to describe young, old, and old. Young is less than 60 years, young old is 60 to 74 years, and old is more than 75 years. Now here you find that the young females, that is aged less than 60 years, the odds ratio for death was 1.88. So that is highly significant, which is not there for the older group. So that is something quite disturbing. And you can see that if you look at the proportion less than 60 years, you find that of people, you find that women as well as diabetes and prior PCI and heart failure and a higher heart rate at admission. These were the factors which affected the outcome. And if you look at time from symptom onset to admission, fewer women than men presented within 2 hours from symptom onset, which is highly significant. And the proportion of women presenting within 2 hours was greater in younger women than the older women. So the younger women did present earlier than the older women. That is 28% in the very young, and that is less than 60, and 21% between 60 to 74, and only 15% above 75 years presented less than 2 hours. Now, again, the same survey, you find that the 30-day mortality was 11.6% in females versus 6% in men. So the highly significant increase in higher mortality. Now the gap narrowed if you take the primary PCA cohort. We find that the mortality was 7.1% in females versus less than 3.9, but still it was still higher. And if you look at the diabetic young women, you find again the odds ratio was much higher. It was 2.04. So what was different? The major bleeding, hematoma, pulmonary edema, contrast-induced nephropathy, door-to-balloon time were all same. Medication use was same, but the total ischemic time was higher in the young, old, and older men, older women. Based on demographics were also, you can find were adverse in females. Delay to presentation was more in the elderly women, and a delay to diagnosis was also there. Now, therefore, there should be caution in young women. So, young women under 60 years, there's a higher early mortality than men. That I've already told you. Now, that is exactly why the system of care for ST elevation myocardial infarction, a policy statement was issued by the AHA, and they get with the guidelines, coronary artery disease in 25,000 patients in the US, from 420 US centers, 2001 to 2006. STEMI mortality was 5.5% in men and 10.2% in women, despite everything. And hospital deaths was mostly within the first 24 hours. And they found that women were less likely in the US to receive aspirin, beta blockers, and reperfusion therapy. Now, if you look at the angiographic severity, the 30-day outcome was almost the same. Now, the mission lifeline was therefore proposed for pre-hospital cardiac cath lab activation, and this improved to 91%, and the use of single center transfer was also improved from 45% to 70%, and emergency department bypass also improved. Now, the regional systems of care have been installed for several years in the US, about 15 years. In India, the STEMI India is there across the Tamil Nadu and 19 states now in India. And the single center studies have shown that it is possible to maintain good reperfusion. Now, what is the component of STEMI care? Well-established standardized protocols, predetermined STEMI diagnosis, activation of the system with a single phone call, and pre-identified transport plans, and get with guideline-directed antithrombotic therapies. And if it's a cardiogenic shock, the patient should be transferred directly to cardiogenic shock centers. Now, this is the schematic. The patient presents with chest pain, immediately to activate the emergency system. US is 911. For us in Kerala, it is 108. And then the ambulance, preferable to have emergency medical services themselves taking the 12 DCG. And if it is a STEMI, bypass a non-PCA capable center and come to PCA capable center. Now, the PCA capable center is far away, more than 120 minutes. It is better to undergo a pharmacoinvasive strategy. Now, delays in transport can be non-system related delays also, longer distance, adverse weather and patient profile, older age and females, absence of chest pain, and fake cardiac cath lab activation. Now, the challenges are high in India because of large sections still grappling with poverty, 80% live in rural areas, poor transport, mega medical facilities, surging lifestyle diseases, and in India, it is mostly out of pocket expenditure. And this is the spoken hub model, which all of us are familiar with. But there is good news also that the incidence of STEMI has declined in the last decade. There is an increasing use of primary PCI, and regional systems of care are at least there now in some states, and standardized protocols and pre-arranged transfer agreements and lesser ischemic time, and more coordination is now there between emergency medicine department, the emergency medicine services, and the cardiac cath lab. Now, this is population access to reperfusion services in this state of Kerala. We have 432 hospitals giving acute hospital care, and you can see the green zone, that is people living within 1 hour, 60 minutes of cardiac cath lab, and the 21% is living within a thrombolysis capable hospital, and 8.2% have no access to care. Now here you can see basically it is the eastern part of the state which have lesser access to care. Now the MCH experience from 2018 to November 2019, we have done 1,537 patients with primary PCI. Procedural failure was 2.5% in female and 1.8% in male. We can see that the mean age more than 60 years was 57% in females, and it was 39% in males, and the mean age was higher in females. CKD was higher in males. Diabetes mellitus higher in females, and hemoglobin was also lower in females. And you can see the total ischemic time. Despite Trivandrum city having 15 cath labs, the total ischemic time is 319 minutes. Door to balloon time was 95 minutes, which is okay once the patient has reached the hospital. 98% successful procedures, and in-hospital mortality of 6.3%. Cardiogenic shock mortality was 61.9%. If you exclude the non-cardiogenic shock, exclude the cardiogenic shock, the mortality is 3.7%. And the in-hospital mortality is twice in females compared to males. The door to balloon times are the same, but the total ischemic time you can see is higher in females than in males. The predictors of mortality, what we found was age more than 60, female sex, and total ischemic time more than 180 minutes. And we have seen that the total ischemic time is higher in females. So conclusion is that access to STEMI care is not standardized in many states of India. Access to care poor in men and worse in women. Younger women, less than 60 years, have a higher mortality than men in the same age group, and women have a higher total ischemic time than men. Despite 60% of Kerala population having access to cardiac cath lab in less than 60 minutes, the mean total ischemic time is more than 300 minutes. And therefore, hopes for the future, the primary PCI should be a right for any patient experiencing STEMI. We should have a proper system in place, intense patient and physician education, women to be educated too, that they stand the risk of a STEMI, and that too with a higher mortality. There should be a plan in every household if a woman who is left alone at home develops a cardiac pain. Thank you very much.